All right, welcome again. Welcome everyone, all of the attendees. Greetings and our warm welcome to our monthly webinar, brought to you by the Institute of Public Health. I am Meitha Shamsi, UAEU graduate with a bachelor's degree in dietetics and master's in public health, and a dedicated health awareness advocate. It's a pleasure to join you all this evening and to be part of this important webinar as we gather to explore the ways we can improve public health and well-being. I'm reminded of the powerful role that knowledge sharing and collaboration play in creating sustainable and meaningful change. This season is part of the global initiative, This is Public Health, dedicated to highlighting critical public health matters. We are honored to have affiliations with ASFER, the Association of Schools of Public Health in the European region. The Institute of Public Health at College of Medicine and Health Sciences is committed to providing a platform for knowledge exchange, networking, and professional development through these interactive sessions. Before we proceed, a few housekeeping notes. Feel free to engage by asking questions throughout the webinar. Simply, you can click down below at the icon of Q&A option at the bottom center of your screen. And inshallah, our Professor Sayed will be answering all questions by the end of this webinar. This webinar is being recorded and will be available on our YouTube channel, Institute of Public Health, CMHS, alongside past webinars. Also, I am pleased to announce that this webinar is accredited by UAEU as 1 CME Category 1. So following the session, you will find a link in the chat to evaluate the webinar. Your feedback is invaluable, and upon completion of the evaluation, you will receive your CME certificate of participation. Now, it is with a great pleasure that I introduce today's esteemed speaker, Professor Sayed Shah. Sayed Mahbub Shah is a professor of preventive medicine in the Institute of Public Health, College of Medicine and Health Sciences, United Arab University, and World Heart Federation emerging leader of non-communicable diseases prevention. He graduated from Khaybar Medical College, Peshawar University in 1986, School of Public Health, University of Texas, Houston, MPH Global Health in 1994, and PhD in Epidemiology in 2001 from USA. He completed a certificate course in the design and implementation of clinical trials from Harvard Medical School in Boston throughout 2015 till 2016. And his research focus is on the epidemiology and the prevention of non-communicable diseases and mental health, beginning in childhood. He co-founded Silk Route Health to improve health literacy about NCDs in Himalayan mountain villages. Previously, he served Aga Khan University, 1989 till 2001, Washington State Government from 2001 till 2005, and Canadian Government from 2005 till 2008. And he mentored several PhD students and Fulbright scholars from USA. Professor Shah was honored with the Best Mentorship Award by Canadian Coalition for Global Health and by Michigan State University. He has published more than 100 research articles and technical reports, and his current research work on the prevalence of NCD's risk factor in vulnerable populations, including children and migrants in the UAE, was recognized by the World Heart Federation, and Professor Shah was honored with the title of WHF Emerging Leader for NCD's Prevention. World Health Organization nominated him NCD's Surveillance Specialist for Emerald countries. The title of our presentation is the following the steps of Sir Robert McCarrison in Himalayan Mountains, Trends and the Prevalence of NCD's Risk Factors between 1995 and 2023. Professor Said Shah, the virtual floor is yours.
Thank you very much. It is an honor to share some of an honor. So I will be presenting, as the title says, following footsteps of Robert McCarrison. Robert McCarrison was the president of Oxford University, and in these mountain villages, he spent 9 months doing some wonderful research. He published a couple of papers on this research. It was in 1917. So I had the honor to follow his footsteps and then do some further work there. And in this session, I will be sharing that work with you. Okay. So these slides, when I completed my training in PhD and medical training, and then went back to Karachi at Agha University, this slide shows the health system operating at that time. And you can see that there are children drowning in the stream, and then there are people who are good in swimming, and as they try to save them from drowning, and then some of them they are unable to save, but most of them die. So this was practically the situation when I joined. It was we conducted a study in Agha University, and this was this picture typically shows this one. So these people who are taking care of them are trained, and they have skills how to go into the river, how to swim, how to take care. So they know that, and they do continuously for some time. And then someone comes here and sees, what from where these children are coming. So he goes upstream and then finds that there is actually a broken bridge. So small kids try to go to the other side, and due to this opening there, they fall in the water, and then down the stream there are people who take care of them, try to save them. So what he did, he fixed the bridge, and then there was no more drowning children in the stream. So this was situation in our healthcare system, because the doctors were trained in how to diagnose a patient. In my medical school, there was typical training that how to diagnose a patient, how to treat, and how to rehabilitate. So these two pillars were there in our health system. So there was not a system where education could flow from hospitals to the community. So it was one-way system where only sick people will come. So for the ordinary people, health means that when they are sick, then they have to go to doctor. And doctors just wait in clinic or hospital, and people come there for the treatment. So lot of conditions, if there was awareness about health, and there was about the promotion of health, and there was some link between the doctors and community, these kinds of unfortunate deaths could be avoided. So it is particularly difficult for people who grew up and live in rural villages, where very difficult, and due to poor literacy, they will go only when the situation is worse, and then most of the time die on the way. It was not only in Pakistan, but many developing countries. So this person, Dr. Mahler, was the first one who did a lot of work on it when he was the Director General of WHO. And he wondered, why this inequity, where so many people are dying, and particularly those who are living in developing country and remote rural areas. And the system was just, when they are sick, they are treated. So he was under his leadership, all healthcare people from all countries agreed in this time in Alma-Ata, where they discussed and then agreed that healthcare system should be such where there is not only treatment and rehabilitation, but there should be prevention. And even better is to promote health. So where we can educate people, and through this, we can address those issues, and people may not die due to quite preventable conditions. So when this Alma-Ata Declaration was declared, one of our teachers, Dr. John Bryant, So he was representing United States government health system in WHO for last 17 years until Almata. And he worked very closely with Dr. Mahler. So he was wondering, he wrote 3 books on biomedical ethics. And he was wondering, he liked the equity concept, that how we reach, if we have 2 resources, how we reach first to those who are more vulnerable. That was the guiding light to spend resources. So he was wondering how this can be implemented in a developing country like Pakistan, which at that time was 5th most populous country, and how, because the system, there was no health promotion system or prevention, all efforts were only treatment and rehabilitation. So he came to Aga Khan University, and then first time Aga Khan University developed a system like traditional medical school from where I graduated. The all curriculum was on treatment and rehabilitation. So he developed a curriculum for Aga Khan University, and then at that time, Michael Smythe, he came from Texas, where he was first to develop a medical school, a curriculum where he included health promotion and disease prevention. So he joined as a first dean of Aga Khan University, and Dr. Brian as the chair of the community health science department. And then they developed a curriculum for both medical students and nursing students, where it is, they get education on public health, particularly health promotion and disease prevention. So, and then there were field sites developed where they can practically learn how we can improve and prevent health. So Aga Khan University was first time introduced the concept of community health workers, because there was no link between doctors, hospitals, and communities. So first time we created prototypes in rural Sindh and urban Karachi, where we develop a new system where we can do health promotion, disease prevention, and then curative care was already part of it. So when I joined Aga Khan University, this was first survey done to assess, why kids are dying, so many kids are dying. And you can see that we noted one of highest prevalence, 170. So out of 1,000 live births in Greg's field site on extreme left. This was the field site. I started my work there as a community health doctor and then as a field director, where the infant mortality were 170 per 1,000 live births. Such a high infant mortality. And when you look at the rural mountain villages up in the north, there were 158 infant mortality rate. So such a high infant mortality rate. So how we address these issues? Because lot of people, I showed the picture, that was the situation when they are very sick, they will come to the hospital and some of the children will die on the way to hospital. So how it could be reversed? So this is the one of the Greg's field site where I directed the program, where this population showed one of the highest infant mortality rate, 172 per 1,000 live births. So this population was multi-religious community, where there were Christian in Father colony, and then Pathan and Baloch colony where there were Muslim, and Hindu para there were Hindus. And this gathering was first time in history that all these 3 religious people came together in one room. And here I am discussing with how we do the baseline survey, why we do the survey, how we identify the problem, and how we tackle the problem. So this was first time that we recruited community health workers from the community. So the Christian community, the Muslim community, the Hindu community, everyone participated, sending educated girls, 12th grade education, and then we trained them for 1 year on the causes of high maternal mortality and infant mortality. So at that time, I was wondering in Greg's, what are the causes? Why kids are dying? Why such a high infant mortality rate? Why such a high maternal mortality rate? So I went to the hospitals where people were going with sick children. And then I got a record of kids who died on the hospital. And when I look at what was the cause of the death, there was only one cause written for every child. That is a cardiopulmonary arrest. But it did not tell, what were the circumstances, what exactly happened. So this was my first study in that time, that I went to every household when there was a death and I asked information why the child died. So at that time, there was one of my colleagues from Bangladesh. I showed him that I want to assess this information. So I just using my own ideas how to know what was the circumstances which are leading to death in these children. So he said that we have already developed a system to do these kinds of things. We call it verbal autopsy in Bangladesh. So he came from Matlab area of Bangladesh, and he gave me first time the verbal autopsy form. So then I used this form and then went to many households. So I did so many households, and then we exactly knew what was the situation. So 32% of these deaths were due to diarrhea. The kids died due to diarrhea, and mother did not know that they can give oral rehydration because mother had no education. And the second cause of death was pneumonia. And why pneumonia? Because they were getting measles infection, and due to measles infection, it will lead to pneumonia, and then they died pneumonia. And at that time, the ORS was there, but the mothers were not aware. There were immunization available, but mothers were not aware. So they were doing this, dying due to this condition. So up in the mountain population, where I will be showing some more steady result, it was high maternal mortality. Out of this, you can see 550 mothers were dying every year in these mountain villages. And the infant mortality 158. When we looked the immunization, it was very low. Only 11% had immunization for measles vaccine and others. But these 11% usually live in cities and they come, but in local population, there was no immunization. So to address that situation, the Aga Khan Health Service, a sister organization of Aga Khan University, developed a program there in mountain population. So where they also recruited, they called it lady health visitor, the educated women, and then they trained, and they created the community health centers where there was a nurse who provide the leadership to these ladies, and then they will go and educate people about why diarrhea and how to control diarrhea, how to prevent death due to diarrhea, how to improve immunization of children so they will not get measles vaccine. So at that time, when I did my first study in this population in a random sample of 4,000 households, I found that there was very poor literacy rate, like 72% of the females had no formal schooling. So that is why these community health worker or lady health visitor train them using pictures so that educate those illiterate people also. And then these lady health visitor will go to schools and educate about hygiene and about other health related information to school children so that school children could improve the health literacy there. And then once they were educated and they came to know that immunization is very important for these children, you can see it is snowing in one of my hometown villages, and they are coming with their kids even during the snowing winter season, because now they realize how important it is to immunize children. Until then, they had no information. So that was why there is such a high infant mortality rate. If we do not educate it this way, even we have recruited 10 or 20 pediatricians, the situation would never have changed, because the pediatrician will take care when they are sick. But women, the problem will not go down because of the circumstances. So the education was important, and then these ladies educated the females, and then what happened after 5 years, the maternal mortality rate from 550 reduced to 68, and the infant mortality rate from 158 reduced to 39. On the other hand, in the whole country, still there was high maternal mortality 500 and high infant mortality 99. And in this population, even in this remote population, due to health education, they got a much better health than what was happening. So the infant mortality rate reduced from this high 158 to 29, and overall in the country, it was still 95. So you can see how it worked, health promotion and disease prevention. And what happened in the Greek field side where I was directing it, we reduced the infant mortality rate in the Greek field side where this was multi-religious population, Christian, Muslim, and Hindus. There, the infant mortality rate reduced after 5 years from 172 to 60, from 172 to 60. And the cost of this program to sustain was 5 cents, because we had an expert on cost effectiveness analysis, luckily, and she calculated all our costs to run this program and to sustain. So every person, every household, if contribute 5 cents, 5 US cents, is this program was sustainable. So it was so cost effective. And we presented our research finding with our leader, Dr. Brian, in first time we attended World Health Organization, and then we shared our result, and they appreciated our work, and they said that this needs to be replicated in every developing country. Now, there is less infant mortality rate, immunization improved, awareness improved, but now people are not dying more due to maternal causes and child causes, but a lot of people are dying due to NCDs. And you know that almost 86 premature death due to NCDs. This here, the red color shows NCDs, the blue color shows the maternal child health and all those issues, and the green color shows the injury-related mortality. But you can see that overall high burden of mortality due to NCDs. And this is true for remote villages and urban cities everywhere in both developed and developing countries. So, and we look at the picture of 2012, the WHO collected the data of the premature mortality due to NCDs. NCDs, 4 conditions: cardiovascular disease, type 2 diabetes, cancer, obstructive lung disease. So these 4 conditions in UAE cause 65% premature mortality. Premature mortality means that people are dying less than 70 years of age. And then when we look at the Pakistan, the premature mortality is 6 to 2% due to NCDs. So now the NCDs are becoming a huge issue. So what happened to UAE? You know, it is economically developed country, alhamdulillah, good resources. But what we expect that it was 2012, 65%. Now what is the situation? Actually, now it has further increased to 70. Why? Because our focus is only on curative care, not on health promotion and prevention. So unless we do not do that, it will continue rising. So that is why it is so critical that we identify risk factors for NCDs and work on to reducing those risk factors. Then we will decrease the burden in the population. So these NCDs are the 4 conditions, as we discussed: cardiovascular diseases, diabetes, cancer, and chronic lung disease. For that, what we already know, we have good knowledge what factors lead to these diseases. If we do not assess these risk factors and control these risk factors, the mortality will rise, increase further. Whatever number of hospital we create, but it will, in the community, it will increase, it will never decrease. So when we look at the global risk factor, this was a very nice study by Dr. Narayan, that you can see the top 5 leading risk factor for these deaths are high blood pressure, number 1, followed by tobacco, followed by high glucose and overweight and obesity, and then cholesterol. So these are kind of leading risk factor for these premature mortality. So WHO discussed and agreed that we have to document these risk factors in the population, and we have to decrease these risk factors. Otherwise, it will increase. So there has been very good work by WHO, but if we do not measure these risk factors, we are not going to know what is the burden. We will not going to know what we made an impact. What is the situation? If I look my own country of Pakistan, there are only 2 provinces where this survey has been done using the STEP survey. They have documented these risk factors, but rest of provinces, including GB in high mountain village, no survey was done. So, and WHO has developed very nice questionnaire to assess these risk factors, so that every country, whether it is Canada, USA, or India, or UAE, or any other country, everyone has to use this STEP survey so that we can uniformly collect the risk factors for NCDs, and then we can learn from each other. So there have been a number of initiatives by different organizations. Here, WHO selected some of us to work as surveillance specialists for regional countries, and we were trained there. And this was initiative by WHO. WHO has done a lot of other important work on this front. And then World Heart Federation also tried to help communities and educate young people with background in medicine and background in public health. So they selected from every region some of us, and they trained us as emerging leader program. Last week we celebrated 10 years of emerging leader program. So the emerging leader program, the think tank people from World Heart Federation, they train us to serve as in the community and government sector to guide about NCDs prevention. Then as Harvard is good in research, so they initiated another program. We call it, they call it Global Clinical Research Scholar Program. This is 1 year training, and I had the opportunity to be selected there. I completed this training, and many of other my fellow emerging leaders got similar kind of training from Harvard. There was very useful training. So what is happening there? One of the key risk factor is the key condition is cardiovascular disease. As you know that we have initially coronary arteries very clean, but as time passes, when our diet is not proper, we not do physical activity, this yellow thing accumulates in our coronary arteries and it narrows the blood flow. So general people will not go to check their cholesterol if they have no health literacy. So they will go when it is very narrow, and then we start pain in left chest due to less blood flow. And sometimes this yellow this detach and then will block this narrow opening there in our coronary arteries, and then people get sudden heart attack. So this is increasing in developing countries, and my village is no exception. There are so many people are now dying, very young people due to heart attack, because their diet changed, their lifestyle changed, and then they have no literacy. So for example, when I conducted first study in 1995, if 100 people had hypertension on our examination, out of 100, only 30 knew, 70% were not aware that they had hypertension. Similarly, when I conducted a study here in South Asian migrant, I took 1,900 random sample of migrants from India, Pakistan, Bangladesh. And when I examined hypertension, exactly like my village, 75% who had hypertension, but they were not aware. So when they will be aware, when they will get heart attack, when they will get stroke, and will they get kidney failure, then they will be a failure. Then they will be, taking care. So, but it will be too late. It has implication for expenses. So instead of hypertension, they will be ended in ICUs with heart attack and stroke. So the UAE government will spend a lot of resources. Instead of that, if we educate these people and we identify their risk factor, we can save a lot of money that we will spend in ICUs. And these people who come here for work, they will go healthy back to their countries. So the cardiologist in Dubai hospital invited me that we are collecting a lot of data and we do not do research, so they were asking help. So I was working with them, and they collected a very nice data where they only recruited people who first time came in heart attack. So this was first time they came to Dubai hospital with heart attack. And when I was analyzing, the mean age of death for South Asian was 48 years. So almost 100, half of them were young people, and at such early age they are getting heart attack. And why? This was the condition. They have risk factor, but they have poor literacy. They only go when they are sick. So this needs to be changed. Otherwise, people are at loss, and we spend a lot of money on this cure and treatment. So globally, almost 50% of global cancer deaths are due to the following three risk factors: smoking, alcohol use, high body mass index. So these risk factors, it is very important to identify these risk factors. And the other important thing is that although NCDs we get in older age, like type 2 diabetes, obstructive lung disease, cardiovascular disease, cancer in older age. But when we look at the risk factor, 70% risk factor developed during childhood. For example, when I was doing this survey in the mountain villages, when I asked, are you smoking? If they say yes, when you started smoking, it was between 10 years to 19 years when 90% of these children got the habit of, in their early childhood, they got this habit. So it is so important that we start from very beginning, we focus on children. It is very important. Similarly, when I look at 6 to 11, so I took a random sample of 8 schools out of all schools in Al, both public and private, half public, half private, half females, half males. I took a random sample of 126 school, 8 school randomly selected. And then I examine elementary school children. And then you can see that there is a dark color and then light color. The dark is that they are overweight and obese. And then you can see various cardiometabolic risk in such young children, like 6 to 11 years here in Alain. And you can see that when you look at overall metabolic syndrome, where the child had more than 3 or more risk factor in its body, then we can see that those who are overweight and obese, 22% had, those who are overweight, 22% had metabolic syndrome. Those who had normal weight, only 4.6% had metabolic syndrome. So this shows that that's why in every session with the medical student, I ask this question: how many have tested their blood pressure, cholesterol, and TG, and very few have tested. So I say that first you do your own test. If the elementary school children get this kind of picture, how we can say that we are safe? So that the important thing is to create awareness both in community and particularly in young children. So otherwise it will be a huge burden on the healthcare system. So look at young children's age 12 to 18 years from this study, that those who are overweight, obese, very high prevalence of hypertension, 27%. It should be like from adults, but these are young children, age 12 to 18 years. So it is with how the obesity is, predisposing these kids so to this important risk factor. So, so I am watching what is happening in my hometown villages up in the Himalayan mountains. So first study I conducted in 1995, where I show the health illiteracy, where in females 72.3% were illiterate. But over the time in 2007, it decreased further to 45, and then 2009 it further decreased. So literacy is improving there in these mountain villages. And then look at the body mass index. And you can see that in 95, a lot of them underweight, very few obese and overweight, and a lot of them green normal. And then in 2007, the red color further increases. And then in 2019, it further increases. So it is growing because of the lifestyle in these remote high mountain villages also. They're And then, thanks to these cigarette companies, they have lost a lot of wealth in developed countries because their action, and now they want to get this money from developing countries. This was very rare, cigarette smoking. No, it is fast increasing in villages like high mountain villages. But good thing is it is gradually decreasing. So in 1995, the cigarette smoking was 43.7%. As you can see, it decreased to 22% in men. Red color is men, and 11.8% in 2019. So whenever I do study, I share with the local people, I share with the healthcare people and other people, so they can be involved in this health awareness thing. And then females, it is very remarkable reduction of period of time. So that is a great news here. And then the most recent one, I completed this survey in a random sample of 2,000 households. And then you can see that the green color is decreasing. Health promotion is green color. If we encourage people there who are normal and encourage them, they will not fall into yellow color and red color. So the health promotion will be focusing on the green color. Prevention will be focusing on the yellow color, where they have already a risk factor in their body. They are overweight or red color, obese. Then if we remove these risk factors, it will be called prevention. So health promotion is very cost effective. It is very nice to say somebody that, wow, what you are doing, your weight is perfect. that person will be very encouraged when he will listen this from doctor. So sometimes we ignore the green color. We measure, and then if they are normal, we do not pay attention to that. We are just after red color. So we have to have a good approach about health promotion as physician and healthcare workers. So unless we identify this risk factor and we decrease this factor, the burden will be increasing and we will be spending more and more money. So we had another, after Almata, this was the second conference in 2015 in Astana, where all these healthcare leaders from across the country was invited, and we had 2 days discussion. The discussion was that there was emphasis that mental health should be part of NCDs. The other one was how we address the issue, how we address this rising burden, both in developing countries and developed countries, how we address that. So finally, they all agreed that the best strategy to do is the way we reduce the infant mortality rate, the way we reduce maternal mortality rate. That is why I shared some of the slides from these mountain villages that they had very high infant mortality rate, maternal mortality rate, but giving awareness, it drastically reduced. So how we use that strategy to decrease risk factor for NCDs? So to start with, we have to first measure the risk factor. Unless we measure that will not happen. So in this Astana conference, my teacher, when I was in medical school, was representing Pakistan. At that time, when I was a student, she was assistant professor in pediatrics. Now she is one of the key person in Senate. So she was representing the situation of Pakistan there in the conference. Like many other countries, there were representation from UAE who also presented their progress there. So, but this was very nice discussion that they agreed that ideally mental health should be part of NCDs. And now in the current survey questionnaire, we see the mental health is there. And this is a high mountain village where I conducted these studies. I grew up there, and every time wherever I am, I always think that what is the benefit of my education to my villagers. So that is why when I was at AKU, when I was in Canada, or when I am here in UAE, I always spend time back in the village, and I try to get some resources and assess these risk factors and educate these people. So early on, people were coming in these villages because 60% of the all highest mountains in the world are located in this area. So a lot of people from Britain at that time, Pakistan, India were part of British Empire. So in 1917, people wrote about the people here, about the population, that they saw so many people who were 90 years old in these villages. So then Robert McCarrison got notice of this thing, and he was wondering how come in England, people are dying at 65 years. How come these rural remote people are living 90 years old? But what is the problem? So he said that maybe it is related to their nutrition, because he was not only a physician, but a nutritionist. So he was at that time the honorary colonel for army. So Sir Robert McCarrison was a physician and nutritionist, and he was also responsible, honorary colonel for army in British Army in India and in Pakistan. So he went up to these high mountain villages, and so Robert McCarrison is the first person who showed a link between our diet and our health. Until that time, we were not knowing. So he did a number of good studies and documented that our diet is related to our health. So that is why he is known as father of modern nutrition. So at that time, there was no road and nothing there in those villages, but he was a resourceful person. So he took, albino rats. So 600 albino rats from UK and went up. He spent 9 months in one of the village, Karimabad, Hunza. So he spent 9 months in doing this experiment, because he was experimenting this role of, nutrition and health in different. So there were some cities in India. So he included this mountain population as part of his study. After listening that there are people living long time, and then he himself saw that there were many people who are 90 years and older, and so he did an experiment. So half of the albino rates, 300, he gave the Hunza diet or the village diet up in the mountains. The other half he gave the British diet. So British diet was white bread, rice meat, and jam. And then the Hunza diet was their own organic, because they are growing wheat in their own land. So they were using it, and they were using all the time vegetable, 7 days a week. When he asked how many times you eat meat, they said 2 times in a year, just 2 times in the year. And then they were, every time they were eating vegetable, and then they were drinking milk, goat milk. And then the other thing was that he says that everybody was walking from morning to evening. So they were physically very active. So they were very happy, very healthy. And he wondered how we can change this thing in Britain so that we can enjoy such kind of longevity and good life. So what happened that at that time, when Robert McCarrison was there working on his study, there was the Silk Road, from here to China. So you can see on my left side, you can see a small road there. So hardly people can walk on this road. It was very dangerous. People will fall and die. So it was on the top left, you can see old Silk Road. And now the new Silk Road, CPEC, China-Pakistan corridor. So there is, like in Dubai, they have this nice road between China and Pakistan. And then at that time, people were using water mill and their own flour, which is a full, organic, and the husk was there. Later study shows that husk prevents from diabetes. So diabetes was unknown. So for example, when I conducted first study in 95, out of 4,000 people, none had diabetes. It was unknown there. But now it is increasing because changing in diet. And at that time, they were the only sweet source was mulberry and apricot and these things. But now they have got sweets because of the China-Pakistan corridor. They have all these things available there. And then instead of, now they have a white flour from these mills. And then at that time, they were not using tea or anything. They were early morning, they were using paste of this apricot, dried apricot, because there were abundant apricots in every house. So they were using this apricot, but later they learned about tea. And then at that time, sugar was not there, so they added salt. So now, when I asked in my study, almost every person drinks 5 cups of salted tea every day. So you can see it is a lot of salt there. And then walking has decreased because there is a road and transportation availability. Nobody wants to walk. So what I did was that I took 1,000 households from those villages which were on the road, and 1,000 households which were away from the road. Still people were walking. There was no transportation facility, the dirt road. So when I checked their physical activity, you can see that in the CPEC villages, low physical activity, more sedentary life. The other villages, more good physical activity. The other thing, I look at the nutrition status, and I had state-of-the-art scales and to measure all this. And then you can see that 11% in the CPEC, where the near road, they had 11% obese, 31% overweight. Those who are away from the road, they had like only 6.8% obese and 20% were overweight. And we look at the hypertension prevalence. So the hypertension was 43.3% in those who were near the road and they were all the time using vehicles, 43%. The other who had only 23, just imagine 23% per 100 and 43. And this Hunza lies in this place where in old days they had such a wonderful health, but now they have such a high prevalence of hypertension. And when I examined fasting blood sugar level, there was more pre-diabetes in those who were on the CPEC China-Pakistan corridor road, this nice road, and those who were in the dirt road, they had less diabetes. So this time, this research was accepted for World Heart Federation, and then they selected this as so I came to know that out of more than 1,000 accepted presentation, they selected 30 and published in Global Heart, and my study was one of these 30 paper. So I was very much encouraged that it was I then realized that it is an important study. So my team, so I had a wonderful team of medical students. These are final year and fourth year medical student, and then there are BSN pass nursing from Akka University. They were my team, and with them we were able to complete this study in 4 rural districts, taking a random sample of 2,000 adults. So whenever I go, I share this information with officers. Here I am sharing this with police officers. And this time I spent all my vacation, summer vacation, presenting the result to the villagers. So these are volunteers and organizers who are taking picture with me. So I was so very much impressed that people, when I'm speaking 3 dialects where these people know different languages. So this is one village. I went to almost 18 villages presenting this data every day, and they understood it when I translate it in local language, explain them, and they are very encouraged. So one of my colleagues came from there, and he was saying, there is some new thing I saw in my village. I said, what happened? When I went there, every person was walking in the morning in groups. I said, what happened to you? You are not walking. They said that Dr. Shah was here. He have instructed us that we have to spend time at least 1 hour every day, either in the morning or in the evening. We have to walk, otherwise we will get diabetes and other heart disease. So it is very encouraging, and I will continue doing this more often in these villages. So I just, as a sample, I'm showing these few pictures, but so there was a very nice gathering, and I shared this step survey first with the people, and then later we share it broadly with through publication. These results will be very useful. So it is these are young kids I saw on the way in the village, and I took pictures, and now it is these are our future leaders. So we have to work for them, and starting at early age, and create awareness and address NCDs to have a healthy life ahead for these remote villages. So thank you very much for your kind attention. So the green color is health promotion. It is very cost effective. We identify, we encourage them to do physical activity, we encourage them walk, we encourage them to get right diet. This is green color. It is very cost effective. Otherwise, when they become overweight or obese, it is very difficult to bring them back to normal. And if we do not pay attention there, if you are obese, then they end up getting heart attack and ICU. It is very expensive for a developing country, particularly people living in remote rural areas. So that is why it is so important. So you are I very much appreciate your attendance, and thank you very much. And if you have any question, I will be happy to answer.
Thank you. Thank you so much, Professor Sayed. It was really a very enlightening presentation. One of the key concepts you have mentioned, decreasing risk factors, decreases the burden of NCDs. By the way, such a beautiful village, Professor Sayed. We really enjoyed the pictures that you have shown, and it was very inspiring to see the way you give back to your people, to the village that you were in. And actually, since we are waiting for questions, I'd like to start with a question, Professor Shah. You have mentioned raising awareness to decrease the risk factors and thus decreasing the NCD's prevalence. at like from 1965 and now, Professor, what would be the best way to raise awareness? Would it be different from the past? And what were the most effective strategies that you encountered?
So as I gave example, how we increase immunization from like 17% to 95%, how we increase awareness about oral rehydration solutions, so where the infant mortality rate decrease. Similarly, we have to communicate with the people. And luckily what happened that one of the organization did a great job reducing this infant mortality and maternal mortality, the Aga Khan Health Services. They have now, for last 3 years, they have included NCDs in their program area. So they are working, and with them, if we all help each, all stakeholders work together and create awareness, because creating awareness, it takes time. So for example, when I was working in this urban setting, so because we were educating also people to have interval between pregnancies, not every year become pregnant is not good for maternal health in child. So I was educating there as field director. And then one of the mosque leader was criticizing, you should not go to the center. They are asking, they are saying about family planning and keeping interval. So that, but what happened that after 3 years, a lady came to me and said, I am, me? I said, I don't know. She said that I am the wife of this preacher who was telling every mosque prayers about against you. But now he has sent me to tell you that he was wrong. And what we are doing is good thing. And that is why I am sending my wife to see and educate her. So it took me 3 years to bring this change. So the thing is that it will not happen suddenly. We will do something, it will not happen. It needs constant work on it, continuous education, continuous thing. Then we can achieve this. So it will take time, but very, very hopeful. I'm very hopeful. For example, previously 70% were not aware. Now 60% are aware in these villages when they have hypertension. But to make it 99%, we need to more work and constant work.
So I think, Doctor, patience is key for raising awareness.
Yes.
All right, so we are opening the floor for questions. Professor Sayed is here to answer questions, so please post any questions that you have. So, Professor Sayed, since we are waiting for attendees to post questions, I was just curious, is it beginning to, or is like the capitalism or the Western diet is actually now moving even to the villages, in the Himalayan villages? How do you think it is changing the changing their diet? How is it affecting their health? And how much
Yes.
awareness do we have to do when it comes to consuming products? Yeah.
So it is a huge problem, because now what is happening is that, for example, in those villages, now there's a new road constructed across the village. And then in this road, people have different shops. And then they are selling these products, which contain a lot of salt and sugar in it. And then even a child, if he or she has money, can go and purchase. Otherwise, there was no such facility in the village, So it is becoming very, very challenging. We need to work very hard at an early age. For example, one of the best program in UAE started is the early childhood program in Abu Dhabi. That is a wonderful program. Inshallah, it will totally change working with the children. So these kinds of program are very, very important.
Yes.
Where we
yes.
continuously educate parents, young ladies, so they be aware of, consequences of this. If we improve health literacy, we can hope a better future, inshallah.
Yes, inshallah. We have here Muhammad saying, I'm very much excited to hear the results of this great health promotion program to reduce NCDs. It's a truly cost-effective program. Thank you, Professor Shah. This is from Dr. Muhammad As-Sadiq. We have another comment saying, thank you so much. It's really it's really an inspiring experience and useful information from Jamila Abdurrahman. I think everyone, as well as I am, Professor, have really enjoyed and felt so much inspired by your work. And I think, do we have any more questions? Would you like to add anything, Professor?
I think it is such a simple presentation, you know, there is no difficult thing to understand, perhaps. So that is why there are. So the important thing is, you know, how we can collaborate with each other and how can we work together to bring changes here, you know, particularly doing creating example. UAE is best place to create example, not for this country but for others, you know. It has resources, and alhamdulillah, Abu Dhabi Health Department has initiated a lot of great programs which is promising. It will take time, but inshallah it will change. So this, then it will be a great example. You know, UAE University is intermediary between developing country and developed world, and what will happen here will be a great example for other countries. So the early childhood program, I contributed in development of that program for 6 months, and it is very promising. So but it will take time, and inshallah it will happen.
Inshallah, inshallah. Thank you so much, Doctor. I want to extend my sincere gratitude to Professor Sayed for accepting our invitation and delivering an outstanding and highly valuable presentation. I also wish to express my thanks to everyone involved in making this webinar possible, including the management of our college and UAE University. Special thanks are due to Professor Michael, Dr. Iffat, Dr. Azhar, Mr. Ismail, Mr. Asajir, Mr. Amino, Ms. Bayan, Ms. Khadija Al-Blushi for their contributions and support. To our audience, thank you for your active participation. Kindly remember to fill out the evaluation link in the chat to receive your CME certificate. We look forward to your participation in our upcoming webinar on January 2025, titled Child and Adult Obesity Treatment Strategies. It will be presented by Professor Paul Gatli, Professor of Exercise and Obesity in the Camigas School of Sport in the UK. He is also a co-director of the Obesity Institute. So mark your calendar. Stay connected with us on our IPH social media accounts at UAEU IPH as viewed on the screen, and you can access all webinars recordings on our YouTube channel. Thank you so much. Take care, stay safe, and goodbye.